Thank you. It's really lovely to be here. Just in terms of contextualizing, to just sort of tell you a little bit about where I come from, to give you a sense of what I'm interested in, because I think it has a bearing on this. I've, over the last 10 years, been involved in a number of randomized controlled trials. The similarity across all of them is that it's using community health workers through home visiting, either through cluster randomized trial or individual randomized controlled trials, and really trying to develop an evidence base in a context of Khayelitsha in Cape Town, as well as a study in a place called Umlazi, a part of Durban, to try and develop an evidence base about kind of what we can do, what works, what doesn't, and how we then have to shift interventions. So the first trial was one on trying to improve the early mother-infant relationship. This was about 10 years ago. We had some very nice outcomes at the time. Infants at 18 months, and women at and the mothers at 18 months. And we're actually at the moment following that cohort up. They're now 13 years old. We got some money from Grand Challenges Canada, the Saving Brain. So we'll have data on whether that early intervention actually has had an impact later. Why that's important is it was very much a very specific, focused intervention. It was on trying to improve the mother-infant relationship. It wasn't. We touched on other things, but that was really pretty much a vertical program. Good Start study, we've just recently published the first outcome paper of that in Tropical Medicine International Health, and that again that was in Umlazi, and again community health workers home visiting, but also less vertical in the sense that it was now trying to improve exclusive and appropriate feeding at 12 weeks of infant age, but then also trying to improve illness detection and neonatal survival, and I'll touch a bit on that later. The Polani study really evolved out of that as an attempt to say, wow, these are really important studies, they're probably not implementable at scale because they're probably too expensive, and that we needed some kind of more horizontally integrated programming that covered a more kind of generalist approach. And these community health workers were very specifically trained and well trained to do a particular thing. And what happens when you add on lots of other things? What happens? And so that's really the context that. Now, a lot of you may have seen this, but I just love this. I don't know. It's probably I've seen it more regularly, but it kind of sums up, I think, my position sitting as a researcher and trying to inform policy, and someone, being asked from someone in a hot air balloon, you must be, suspended vertically above the ground over as a means of descent. You must be a researcher. Yes, how did you know? Well, you're full of technically correct information that is totally irrelevant to my current situation. And you must be a policy maker. How did you know? Well, you don't know where you are, you don't know what to ask to find out what you need, and you're blaming other people for your current situation. And I certainly have this experience often in trying to communicate with policymakers and trying to make what I believe to be important and what the constraints that they're sitting with. So obviously, speaking to this group, everyone here is aware of the significant care burden carried by women and girls in low middle income countries. From a mental health perspective, that women are twice as likely as men to suffer from depression, and obviously at greater risk of experiencing gender-based violence. And that what has happened across the health spectrum, so this is not about mental health, is that there have been very effective studies that have happened, sometimes at fairly large scale in a randomized controlled trial, but then the moment they scaled up, they fail, often quite dramatically, given some very positive results when they studied, when it's in a small effectiveness context. And people often talk about that part of the main reason for that is actually that you've got a group of researchers who are having a very tight control, so they really watch fidelity, and I think that is a core component. But what I want to try and bring out in the course of this discussion is really that I often think that even when there's fidelity to the actual intervention, that when they're taken to scale, there's sort of a triad which I'll speak about later, and it's the training, it's the recruitment, and it's the supervision and management. And those, when you take it to scale, are the first things that fail, and that's why they're failing. And from a research perspective, those are the boring stuff. Nobody gets published in The Lancet for a paper on supervision. And so people interested in reducing neonatal mortality, that'll get you published in the Lancet. Actually improving the supervision and management of a project at scale to reduce neonatal mortality, no Lancet, people aren't investing in it, and I think that is hugely problematic, that we need to be much more engaged and working at, and I'm saying boring in a particular kind of way, it's central, but I hope you get what I'm trying to get. So trying to reduce this gap between these small scale, either efficacy or even effectiveness studies, I think, particularly in the context of women and girls, is that holistic programming is important. The idea of going into a household where we work in Khayelitsha as an HIV counselor, and then actually ignoring the mother-in-law who's got Alzheimer's or the other illness or the violence or whatever, I think is problematic, and that actually we need some kind of holistic programming. I think a lot of people are cognizant of this and are moving in that direction. As I've said, consistent supervision I think is absolutely central, and then obviously an enabling policy environment, and I'm going to talk about this particular South African situation in that regard. This is a busy slide just to sort of as a way of thinking across the continuum of care when we think about holistic programming, the kinds of things, and this is a non-exhaustive list, there are many other things we could add in there. But I would argue that at various stages across that continuum of care, right through the life of the infant and then the child, that any number of things are absolutely vital at all those stages. And how can we develop a system with linkages to the health system, but through a process of community-based home visiting, how can we make sure that as many of these can get done in a cost-effective way as possible, and very importantly, in actually delivering a good service. So a lot of when we talk about community health workers, it's often within the context of a task shifting model, where tasks from higher cadres of workers, doctors get transferred down to nurses, nurses get transferred down to community health workers, and the idea is to ease bottlenecks in delivery. There simply aren't enough of the professionals in those countries. The way in which task shifting has often been thought about, it started out as task shifting, and then it became many nurses, for example, they started describing this task dumping. And so that now I think that the politically correct way is now task sharing. So everyone's happy with this notion. But somebody gave a metaphor of a bit of what's happening at the moment. The community health workers are, if you can't get a nurse to do something, if you don't have enough nurses or you don't have enough doctors, we'll just give it to the community health worker. And it's a bit like a goose being force-fed for foie gras. Just more and more tasks. And to what extent is this possible? Most community health workers haven't, in fact, probably all of them haven't got any post-school training. Many won't have even finished school. In the South African context, most of our community health workers have finished school. But what's the limit? What's that limit in terms of being able to give yet another task to a community health worker and then train them effectively and get them to deliver that effectively? And calls last year by Singh and Sachs in the Lancet about 1 million community health workers. It's great, but that has certain implications for recruitment, training, and a whole number of other things. And I think that's often not at the forefront of the way we think about it. So I'm a clinical psychologist by training. I would probably see myself more as a public mental health person now, as opposed to a psychologist. So and my main interest has been in maternal mental health. We've done studies on postnatal depression, on antenatal depression, and increasingly mental and behavioral disorders are accounting for ever larger amounts of years lived with disability. And coupled in Africa, where I'm based, is just under 50% of African countries don't even have a mental health policy, and only a third have a mental health plan. And even those that have a mental health policy, the extent to which that actually is actually acted upon or implemented is questionable often. And this is something in PRIME, and so PRIME is the Program for Improving Mental Health Care, and it's a RPC, DFID funded, in 5 countries, and the countries are South Africa, Uganda, Ethiopia, Nepal, and India. And the idea is to develop an evidence base of not so much what works, because we have a lot of evidence of what works, but how to do that in practice, how to integrate mental health care into primary care. And we're about halfway through at the moment, about to go into full implementation phase, and then towards the end of the RPC there'll be a scale-up phase as well. And a lot of it is trying to address the treatment gap, that the gap between those with disorders and who receive any treatment in many countries in Africa, for example, like Ethiopia, is as high as 90%. And in fact, it's very high all over. In the United States, I think it's 37%. So it's very high. This is not just an issue for low and middle income countries. As I said, I'm particularly interested in maternal depression, and anxiety and depression are the third leading cause of disease burden for girls and women between the ages of 14 and 44. There's been wildly divergent kind of data around antenatal depression, postnatal depression. So the first study we did in Cape Town, we found at 2 months postpartum a rate of postnatal depression of 34.7%, over a third. We've never found anything approaching that subsequent to that. It's always been quite a bit lower. And there was an interesting paper published a couple of years ago by Parsons and Rashan and colleagues, where they looked at countries in low middle income countries who started doing studies on depression and anxiety, and they found that every country that had 1 or 2 studies, the prevalence was very high. And as the number of studies were completed, that then kind of settled on a more realistic figure. So, and I think that's an important thing to remember, particularly because there's, in global mental health, there are a lot of skeptics about global mental health who think it's about imposing a Western psychiatric model on poor countries. And I think when you go in with a figure of 49% of people are suffering from depression, I actually just don't think is useful in a sense, because then what's the tool? So we have to be very, very clear about our data, I think, and what we argue. And suicide is a leading cause of death in rich countries and in many poor countries. So this is this was our study with Peter Coop and Lynn Murray and colleagues in 1999. In our control groups in our various trials, the figures at 2 months postpartum approach more like 25-26%, so quite significantly low, still higher than the rate that you'd find in rich middle income or in high income countries, where it would be about 15-18%. So still a difference, but not as marked as that. Now, obviously, the women and girls have very particular mental health needs, and as I've said, the risk of depression for women is nearly twice that of men. Psychological services are more commonly accessed by women, probably more due to help-seeking behavior. So that cliche of women seeking help and men going to the bar, I think, is to some extent true. And obviously, adolescent birth rates in many low-middle countries are very high, and this has long-term mental and physical health consequences, both for the mother and for the child. And depressive symptoms in adolescence place adolescent girls at risk for a number of HIV infection, STIs, and unintended pregnancies. Briefly, just to set the scene for South Africa and where South Africa is at the moment, and it's a little bit in flux at the moment in terms of the health policy development, that prior to 1994 of democracy in South Africa, and even to some extent for quite a number of years afterwards, the public health system was very fragmented within itself and fragmented between the private and the public sector. Inadequate human resource capacity, poor leadership and management, and obviously the impact of the HIV pandemic. In our trial in Good Start, just to give you an idea, the sample size was just over 3,000 women in Umlazi, and the antenatal HIV prevalence rate in that area was 41%. So the impact of that on, and while I was doing this case study, I interviewed somebody who wouldn't allow himself to be identified because he had a lot to do with designing health policy. And he actually said that if it wasn't for HIV in South Africa, with the resources available, everything would be on the table. Mental health, everything, and it would be an integrated system, but that the stress that HIV and trying to get, and the aim is to get another 1 million people onto ARVs in the next 5 years, that kind of, in a sense, pushes everything to the margins, which when trying to get mental health onto the agenda is obviously, it makes it quite difficult. And insufficient. It's still very much a disease treatment model rather than a prevention model, and this has been the case prior to the current health minister. So our current health minister, who's been a ray of sunshine compared to our previous health minister, who believed, I think, garlic and tomatoes could cure HIV, he's transformed the South African health system. There's still many problems, but he has transformed it, and part of his thinking was informed by a visit to Brazil to learn from their family health program. And so the aim is what's become known as the re-engineering of the primary healthcare package, which emphasizes population-based health outcomes and tackled through primary care outreach teams, and those are a big component of those, and I'll talk briefly now, is community health workers. So prior to this is South Africa has a lot of up to 70,000 community health workers. The model is that the South African Health Department gives money to the NGOs. They do the hiring, they do the training, and they then do the supervision of these community health workers with very little monitoring, in fact, of what actually happens. So whether they're getting the training properly and whether they're actually being supervised adequately. So and one can see the problem. So 2 years ago, we were approached by the health department. They were doing a pilot study of this re-engineering system in the Northwest province, and they were starting the training in 3 months' time, and they were coming to get our manuals for training, and they were going around the country collecting manuals. Now already there's a problem. You can't just in 3 months develop a program, to train 5,000 community health workers. But I also accepted the need. There was a push from the health department, and they needed some evidence. So I then gave all our training manuals, and that was it. They were trained, and then colleagues of mine at the Medical Research Council were hired to evaluate that training manual. And there was lots that was very good about it, but there was also lots that was terrifyingly bad about it in the rush. So two of the things being, and the two things that really stick in my mind, was that 5,000 community health workers were trained, and in the chapter on exclusive breastfeeding, the whole chapter in the manual, there wasn't a single picture of a breastfeeding woman. It was all bottle feeding. And then in the section on iron deficiency, maternal iron deficiency and trying to prevent anemia, one of the recommendations was caviar. Yeah, so now I think it's fantastic that the health department evaluated it and then took the input and changed it. But so their training will be improved. But there are NGOs right now in South Africa training, because it has to come from somewhere. That didn't come from the health department. They were just collecting. So that's in there somewhere. And so this fragmentation is a huge problem, and the quality is an enormous problem. So this is just a picture of the primary healthcare model. The part that I'm particularly interested is in these primary healthcare outreach teams. And here's a picture of the outreach team. So there's a facility-based component. So the Brazilian models are very much around a kind of ensuring very strong linkages between the health system and then community-based care that's happening within the communities. And so I think that's the model that is being suggested. And the facility-based will consist of a professional nurse, a team leader, 2 staff nurses. And then in each team there'll be 6 community health workers who each of them will be responsible for 250 families. And the idea being is this is not just about HIV counseling or not just about maternal and child health. This is really covering everything. So I think it's quite an ask. 250 households is a lot. 250 households, if you're only doing, like in our Good Start study, maternal and child health, is not so bad because many families aren't pregnant or having a child. This is much more of an ask, particularly when it comes to the supervision and the management. So now to talk about Palani. So in the context of that which really is much more of an enabling environment, policy environment, to actually now look at community-based programs that are effective, that have good recruitment, good training. So Polani has existed since 1979. It was started by someone called Dr. Ingrid LaRue. Bishop Tutu is the patron of Polani, and in fact Ingrid is a medical doctor, and she's the personal physician of Bishop Tutu. Her political credentials are as immaculate as you can get. I mean, there's very few people, so when Nelson Mandela had been partially released from Robben Island and was sitting in Victor Verster prison outside Paarl before he's released, there were meetings between the previous National Party government and the ANC in Mandela, and many of those happened at her house. Everybody was smuggled in and they had the meetings, and so she was at the forefront of what was happening in Crossroads in the 1980s, and quite literally holding dying children, waiting for the bullets to stop and then running out to get to a hospital. And so it's got a pedigree and it's got a relationship with the community that's taken 29 years to develop, and she's very open to actually testing her model in a randomized controlled trial, which is actually quite rare and I think quite brave. You do something for 30 years and now you say to somebody, come and test it, and in fact what it could show is you're not doing anything. So I think incredibly brave of her to do. So a partnership was formed between Polani, Professor Mary Jane Rotherham Boris at UCLA, myself at Stellenbosch, Professor Carol Worthman at Emory, Mary O'Connor, a whole team of people to do a cluster randomized controlled trial. The initial trial, which involves a baseline measure during pregnancy, and then visiting through the rest of pregnancy, and then through the first 6 months to 12 months of the infant's life, and with assessment points baseline, 2 weeks after birth, 6 months after birth, and 18 months after birth. That was all funded by the National Institute on Alcohol Abuse and Alcoholism, one of the NIH institutes. And we then were lucky enough to get funding from Ilifa Labantwana, which in fact is a local South African funder, which gets sort of an amalgam of a lot of other people doing, giving money. So UBS Optimus in Switzerland gives some money to Ilifa, Alma Foundations, DG Murray Trust, they provide a pool of money. And so Ilifa do a lot of early child development stuff, and they were interested to see, in trying to think about the school readiness of children to move away from a kind of at the age of, in the UK, I think kids go to school at 4. In South Africa, it's 6. But that school readiness somehow magically happens at 5 years. That in fact, school readiness starts during pregnancy. And so they wanted to see whether we could develop evidence. So they've now funded a 3-year follow-up, the children at 3 years, which we've just finished. And in the next 2 weeks, we're about to start a 5-year follow-up. So we'll have longitudinal data on those children and mothers and families from antenatal through to 5 years. So community health workers are absolutely core to the Polani program. That's the core of everything that they do. They select community health workers based on this odd name, this thing called positive peer deviance. Many of you probably heard about it. The idea that women living within the community who themselves face many of the same adversities and stresses, but have managed to raise very well-functioning children. They'd be the positive peer deviants. And is a very thorough recruitment process, which involves everybody. Many NGOs, in my experience, what happens is you have the director and one other who do the recruitment here. Not everybody in the organization, but there's representatives from every level in the recruitment process. So from the director down to the person who does the sweeping, to try and get different people's input about what makes this person good or not. And then many more women are chosen to undergo the training than will be needed for a particular program, for example. So if they need 10 community health workers, they'll train 30. The idea being that once you select it because you have potential is in no way actually related to whether you are actually trainable. So the idea is that the training becomes an evaluation as well, which I think is a very, very important innovation. I'm sure lots of other people do it as well. People drop out of training, but this is very systematic around reducing that number of 30 down to 10, but at the same time having 5 or 10 on a waiting list for when people leave, because attrition remains high, less so I think in Palani than in many places, and I'll talk a bit about that later. There's a whole number of monitoring situations, mechanisms which I'll talk about, and ongoing supervision and feedback all the way through. I don't want to focus too much on the actual method. We have a trial protocol paper. The first outcome paper has been published. I can distribute it if people are interested. It's a cluster randomized controlled trial. Takes place in Khayelitsha and Mfuleni, a number of neighborhoods within the two areas. And each neighborhood comprises about 450 to 500. So if you think about that potential model of the re-engineering, it's a little bit more than that. And while this is very much a more generalist model, so the community health workers here are dealing with maternal health, child health, HIV, TB, nutrition, a little bit about some about maternal mental health, and we'll talk about that, and alcohol use. So it's much more of a generalist model. So much closer to what is envisaged within the re-engineered primary health care package of the Department of Health. So, accessing child grant I forgot about. So a whole series of things that are a part of this package. And one of the things that we tried to do here was also to, in a sense, empower the community health workers. Very often what happens, so in our Good Start trial and our Tulasana trial, the mother-infant interaction trial, is that they're very set visits. Set visits happen at a certain time, they're a certain length of time, and then the community health worker leaves. The reality of people's lives is it doesn't work like that. If you're supposed to visit at 2 o'clock on a Wednesday, someone might be sick, and so what happens, I think, in many community health worker programs is that, like one of the things about community health worker programs often is they've got lots of lovely materials, lovely brochures, which can be useful, but also I would argue very often are a barrier. So what happens is you have a kind of a situation where there's a lovely booklet, and the community health worker sits and shows the pictures and explains a bit and then takes it over, and there's no counseling, there's no relationship building, which is at the core of the Palani model. If you don't develop a relationship, I think it's curtains. And so these fancy materials that often get left, I think, are a barrier. And the community health worker walks out and ticks and says, I've done the visit, I've done my job. What we tried to do was to empower them to say, and we used mobile phones, and I'll say something about that now, is that is on the mobile phones, they've got the power to say, I didn't complete the visit, or it was only this long for this reasons. These were the messages I did manage to cover, but I'm going back tomorrow. And because of that, what we're able to do in the study is actually also to develop a dose. So it could be 10 minutes now, an hour tomorrow, 4 hours the next week because there was a big crisis and something had happened. But we get a very good idea of dose, and we can link that to risk factors. And so a very much more kind of a real world situation rather than this absolute hour that has to happen at a certain time. As I've said, we started using mobile phones for data collection about 8 years ago. So we have the only thing that we have that's paper anymore is, so DFID would be very happy about that. The only thing we use for paper is informed consent. That's the only thing. All data collection, virtually all the supervision management happens using a mobile system. And it's become an essential part of, very often in community health programs around Africa, supervision is seen as admin supervision. Did you do what you were supposed to do when you were supposed to do it? That's supervision. And of course, that's the administrative component of supervision. There's a whole other component, the emotional support of supervision, which I often think doesn't happen. So this part of it, the mobile phone, is that administrative component. It doesn't provide the emotional support, but it assists in scheduling visits. We're busy working with the people who develop the system to develop algorithms that the community health worker can use. For example, say wake up in the morning, and what happens, the community health workers usually walk to where they're going. There's often no transport, or they don't have money for transport, and they've got 5 people to visit or 4 people in a day, and they go to the one person and they realize they're here, now the other person they've got to go to is over there. So we're developing algorithms to help them develop a route on a day which would be the best, which would save you the most time. We're also working on trying to develop algorithms around risk. So reminders, you walk into a household, you put the ID number in, and an algorithm will come up and say, remember that little Sipho is supposed to go for his 6-month vaccination. Check that it happened. And so as they would walk into the household, there'd be a few checks, not a lot, because that often then also is counterproductive, but some measures. We didn't do this in Polani. We're busy working on that. And here it's a little bit unclear but this gives you an idea. It'll give you the date of every visit that's taken place with a click. I can log on and look at the system from here. At any moment I can know who's visiting who, how long they were in the house, when they were there, and you can see the thing I've marked there in the block in yellow is that starts giving you some idea of the messages that were covered, the time that they were spent in the house. And so just on that console, we have an enormous amount of information. And I can check also which of my supervisors or research managers have actually been logging onto the system and when to do what they're supposed to be doing. So it helps. So there is definitely a kind of a component of admin and big brother in a way, but that's just one small component I want to stress. Just very briefly, this is the sample is just over 1,000 women the PIP is the intervention group. That's the Polani Intervention Project. And as I said, we did a baseline and then a post-birth assessment at about 2 weeks, and then 6 months and 18 months. Just as two highlights of the demographics of the sample, just the very high levels of women who actually are not married, who are single, very, very high levels. In the Good Start study in Umlazi, it was even higher than that. It was close to 70% of women weren't married. And I think in South Africa that's a very big issue. They're very, in a context of very high unemployment, getting married for culture, there are a lot of cultural reasons that make it incredibly expensive to get married, because there's lobolo that's got to get paid. And so marriage, the poor of the often doesn't happen because of the expense. And we could have a debate. I think there are huge implications because of that didn't play out. I think in terms of how men experience the world and their agency in the world, but that's another debate. And also very high levels and this is in Cape Town, which is, where the levels of poverty are nothing like rural Eastern Cape, not even nothing like Durban, and still huge numbers of children and women going hungry in the last week. So the 29% at baseline, 29% of the women were HIV positive. So not 41% like in Umlazi, but still very high. When we first wanted to do the study in Khayelitsha, we were told that African black women in Khayelitsha don't drink. No alcohol use. That's a coloured phenomenon, mixed race phenomenon, particularly in the Western Cape. Black women don't drink. We did it anyway, and we found that between the time of conception and before the woman knew they were pregnant, upwards of 25% were using some kind of alcohol, which for fetal alcohol syndrome is the most dangerous time. That's when you get the facial features. The very, very good thing about the study is that alcohol may have been happening, but we've looked at fetal alcohol syndrome at 18 months and it's very, very low. So what's happening is the alcohol use is obviously quite low. It might be one drink. It's certainly not binging. So that's a very positive thing. But anecdotally, I think 10 years ago, that 25% would probably have been zero. So I would argue that in terms of alcohol use, and it's something I've become increasingly interested in, is that's likely to grow, and now's the time to start trying to think about how to do something about it, not waiting for fetal alcohol, which just becomes an intergenerational difficulty and very, very difficult to shift. 17% low birth weight infants, and approximately 30% of women depressed mood. In this study, we didn't do a diagnostic interview, so of that 30%, probably 18 to 20% were actually clinically depressed. This is just using the EPDS, the Edinburgh Postnatal Depression Scale, who had risk for depression. The paper that's on the right here, that's the 6-month outcome paper that was published in AIDS last year, and I can send that around, which showed there were a number of improvements across the the PMTCT cascade, around exclusive breastfeeding. So there were, but very important changes, but quite small changes. They're significant, but not huge changes, not with enormous effect sizes. And I think that has very important implications for these kinds of generalist models. That you've got here a Polanyi program. I'm probably jumping the gun here now. It's one of the things I want to say in the discussion, but you've got good recruitment, very good training, probably one of the best supervised systems ever, and it has an impact, but they're not huge. And so that needs to be held in mind when we're thinking of generalist models, especially if we're now going to add on something like, for example, a specifically targeted program for improving mental health, for example, or treating depression, and I'll talk about that now. So one of the things we're very interested in is the impact of antenatal or postnatal depression then on infant and child outcome. In the Polanyi study, there's a component of maternal mental state, but if women screen positive, there's no specific treatment available, so they don't get treated for it. If they're suicidal, they will be referred. From an ethical point of view, that will happen, but there's no specific treatment for the depression in this particular study. And if we look as a main outcome of the study, basically depression doesn't improve. There's no difference between the depression in women antenatally in the intervention control group, post-birth, 6 months or 18 months. There's no difference. So the intervention doesn't impact the depression. But in the context of high antenatal depression, very interestingly, there is an impact on the infants. So despite the fact that the mother's depression isn't improving, there's benefits for the infants. So for example, infant health is improved at 18 months. Very importantly, infant height and weight is better at 6 months in women who were in the intervention group who had antenatal depression than women who in the control group had antenatal depression. So something is in a way happening through the mothers to the children. There's an impact on the child. It's possibly around the nutritional components of the intervention, around feeding, around hygiene, around daily care, around routines maybe. But I think it is an important finding. And one of the reasons it's very important, I think, is because the data in this area are also variable. So Atif Rahman and Vikram Patel 10 years ago had their studies where they found antenatal depression, postnatal depression strongly related to infant growth, stunting at 6 months and at 18 months. When they published that, we then looked at our data. We found no relationship. So you've got, I think, Brazil, India, Pakistan, Nigeria, there's an association between maternal depression and infant growth. South Africa, Ethiopia, Malawi, there's none. Atif Rahman, who's done really kind of groundbreaking work in Pakistan treating maternal depression, he found that relationship between maternal depression and infant nutrition and growth. When he did a trial to treat depression, his main outcome was improved infant growth. That, because of his epidemiological work, that was his outcome. Treating depression amongst Pakistani women in Rawalpindi didn't actually impact on child growth. The treatment halved the level of depression, so a massive effect on depression, but somehow that didn't get translated into infant growth, which you would have expected given the epidemiological findings. So we just don't know. I don't think we know exactly what's going on. So we need lots more data to try and understand this relationship. So this is one finding, that you can improve growth, and we've also found an impact on using the Baileys on the child's cognitive development at 18 months. Again, in the context of antenatal depression. So there's no impact on infant cognitive development at 18 months control as a group effect. There's nothing there. But if the women have antenatal depression, there is. So again, a lot of work still needs to get done to try and understand what exactly is happening here. But I think it does have important implications for programming. And what might be happening is that if you think about depression as in maternal depression as moderate or kind of like not too bad, moderate and severe, is that what's happening is the intervention, even though it's not reducing the scores, is making the group with moderate to low scores just function that much better, but it's having no impact at any level on the severe group, which theoretically and from the data it would make sense that in fact if you want to improve depression, you have to treat it. you can't just like accidentally impact on it. And in our Tulasana mother-infant interaction work, a similar thing happened. No main effect, although there was a trend. It wasn't significant, but there were less depressed women in the intervention group, the control, but it didn't reach significance. Now, there was a lot of focus on the relationship between a mother and infant. We know that in that early relationship, it's incredibly bidirectional. So a depressed mom with an infant, what infants do is that they start to withdraw from that interaction, because they're not that bidirectional attunement isn't happening, and that the more they feel that their interacting partner is out of sync with them, they withdraw more. And if you're depressed and you're trying to engage and the infant withdraws, my argument, and I think Lynn Murray's got good data on this, then you're more likely to then get more depressed, which then has an impact on the infant as well. So shifting that relationship actually it doesn't treat the depression, but it can have a significant impact on that. So just briefly, I've said some of this, that Polanyi's had modest but significant differences in many areas that have been addressed. We would argue that, and hopefully as we go in the follow-up, we'll show that those early changes, those early improvements may become magnified over time. And there's quite a lot of data that, so Ray Martorell's nutrition work has shown, that there was huge benefits early, then they kind of almost all disappeared. They weren't seeing any. And then when they were adults, those children had huge impacts in terms of salary, in terms of employment, and so there were big productivity gains later, but it disappeared, probably because we just didn't know what to measure, in the interim period. The work of Plunken and Wood around life transitions are incredibly important times. It's because anybody who's ever had a child knows that everything you thought about life before is now slightly different. I worked in a children's home for 10 years. I worked with infants. I had children late, and I really thought I was going to be good at this. I really thought this was going to be a walk in the park. Everything gets and so those are the times you really want to make a change. That's the time to jump in there, actually. It's, and I think that's what we're trying with these community-based programs. So just some issues around, I think, what Polanyi offers to this re-engineered healthcare system, and which I think are important, is that attrition is a huge issue in community health worker models, whether globally. It's a huge, very often they're volunteers, and if they're not, they're stipends. So people use it as a way of getting a certificate, a training, a little bit of money, and they're always looking for something else. And that is an issue. And so part of the response to that is going to have to be structural. No one organization is going to be able to resolve that. I think the re-engineered health system, the plan in South Africa is that they will be paid from within the system, and it will be a living wage. I think that'll be a huge, a huge movement, a move in the right direction. But I think that Polanyi, because of their ongoing high-quality supervision and ongoing capacity development, have a very low attrition rate compared to other NGOs. People feel community health workers feel contained, they feel held, they feel heard, and they feel emotionally supported. And of course, if they were offered a job that paid twice, they would take it. But for some reason, they last longer. Whereas in many of the other NGOs, that doesn't happen, and I think that's vital. Obviously, the salary that has to be fixed. In South Africa and many countries, community health workers are walking vast distances to get to places, and they themselves are often women that are struggling with interpersonal violence, partner violence, depression, all their own adversities. Then they've got to walk, do all their normal care burdens, and they've got to go and now care for another family, and they may have to walk an hour to get there. I think we're asking a huge amount, and so we need to find whether it is bicycles, whatever it might be, to at least start the process of easing some of those. Obviously, salary is a huge part of that. And we need models around supervision that provides an emotional support. These community health workers are hearing some of the most appalling stories day in and day out, and they're expected to just hear it and then get on with it and put it in a little section somewhere in their mind and forget about it, and on they go. And I think it's too much to ask. And I think many of them of the community health workers I've had contact with, in fact are suffering from mild PTSD some of the time. They just have had experienced so much. A very interesting experience we had recently in another study we did, which is a community cohort study with Lorraine Scher from UCL here, and it was to look at children cared for by community-based organizations in Malawi and South Africa. These are tiny CBOs that sometimes don't even have a telephone, let alone a website. And they're funded by a whole series of funders who gave us access to them, and we followed these children for a year. The data collectors came back one day, and we were having a debriefing session, and then they started talking. And they started talking about hearing about the corporal punishment. This is not even about some of the extreme stories around sexual abuse or violence, but just corporal punishment, some extreme corporal punishment. I was listening, and I heard it, that these stories were terrible. And then at one point, the one woman said to me, one of our data collectors, this is not someone doing an intervention, she said, no, you're misunderstanding me. It's not that the story is horrible, but I've heard worse stories a lot of the time. The horror for me was we're interviewing the children as well as the parents, and these children are telling us what it feels like to be beaten with a plank and be hit like this. And all of them started saying, and two of them in particular said, I did that with my children. I feel that was what we did. The priests tell us, the pastors say to us, you must hit your children because that's what God wants people to do. You spare the rod and spoil the child. And I can't believe what these children are saying to me. And so one was, it's too late. So she was traumatized, literally, because she'd now been hitting her child, and she's the most lovely woman, it's not. And then another woman who's still got a child was able to say, I'm never going to hit them again. And so there's this huge impact just on the data collectors, on the stories they hear, and then how they translate that into their own lives. And so what that must be like for a community health worker who's seeing that sometimes, let alone just hearing it from someone in an interview. Polani gives transportation stipends if the distance is over a certain amount of a certain distance away. I think that's hugely important. And as I keep saying, this administrative versus the supportive supervision is vital. The way that Polani recruits the workers, I think, has huge lessons for this re-engineered primary healthcare system. As I said, rigorous interview process, more women selected to be trained than will actually be hired, and then an evaluation of the extent to which they're actually being trained rather than just the potential to be trained. And I don't think that's the case in most places. And the supervision, training, and management, this triad, which I think has to be foregrounded more in terms of the interventions we do. This is what's, we've actually probably right now, with all that's happened in the last 15 years in the area of neonatal survival, nutritional, we know a lot about what works. We really do. We just don't know how to do that at scale. And I think these three are one of the core components of that. And if we can start thinking about different models of supervision, how to train, how to recruit, how to cascade training, how to cascade supervision in effective ways, we'll be answering a lot of where we actually stuck globally. I've spoken about Atif Rahman's work and the depression and the infant growth outcome. As I said, it appears that unless mental illness, particularly the severe, is directly targeted and treated, the benefits of women's mental health may be marginal, and that is a big component that we have to be thinking about that. But thanks to DFID in Prime and thanks to NIMH, who've got a series of hubs at the moment. So one hub in the moment is happening is called the Affirm Hub in Cape Town, using the Polani community health workers, a certain cadre of them, to see whether they can be trained to treat depression. So that's Crick Lund and his colleagues, and so that'll provide some data on that. The next step, and obviously Crick and I have spoken a lot about this, is that we've had this Polani model, this generalist model, which we've shown to be effective. If his Affirm model shows that you can treat the depression, can we then put those two together and have the same impact that we did at the Polani as well as on maternal mental health? So him and I are talking about a few years down the line of doing something like that. And I think the data that's going to come out of Prime is going to be central as well, because this is at all three levels. It's at the health organization level, the highest level, health facility, and at the community. And there's a strong component on maternal mental health. My last point is something around a term that McCoy and colleagues phrased about acting urgently. sort of a tension in building slowly. There's this tension if you're in a context of lots of people, lots of babies dying, that you have to do something about that quickly. And of course you do. But in fact what happens is a lot of interventions are just thrown out there to do something quickly, and they don't work. And it's actually a waste of money. And we have to find a balance between a long-term vision, the building slowly, and that's where the supervision, the training, the management comes in. Yeah, and so I'd like to thank the women and children and funders, and yeah, thank you.